Hello, let's talk about ALL. Leukemias and lymphomas are white blood cell cancers. And in order to talk white cell cancers, vocabulary is very important. So we are going to spend some time here at the onset of this SDL making sure that everyone has their terminology down pat. Okay? So a leukemia versus a lymphoma is a matter of location. A leukemia is a bone marrow cancer that can be found in the peripheral blood, and a lymphoma is a more localized white cell cancer that's usually confined to a lymph node or a string of lymph nodes. A good way to slice up different leukemias and lymphomas or classify them is simply based on the course of the disease, acute versus chronic. And this is a literal distinction. An acute leukemia is more rapidly fatal, sometimes even in weeks, versus a chronic leukemia or lymphoma that has a more indolent and gradual disease course. Another way to slice up leukemias and lymphomas is going to be based on their cell of origin. Now, white cells can develop from either myeloid or lymphoid lineages. Examples of myeloid white cells include neutrophils, eosinophils, and basophils, those granulocytes, as well as the monocyte. But examples of lymphoid white cells include T lymphocytes, B lymphocytes, and natural killer cells. So no matter which direction you go in the hematopoietic division tree, you can get a white cell cancer. And so if it's the myeloid lineage, you're going to get a myeloid cancer. If it's the lymphoid lineage, that's a lymphoid cancer. And so the way that we tell a myeloid from a lymphoid leukemia or lymphoma is going to be based on cell surface staining and immunohistochemistry and flow cytometry. So that ought to make intuitive sense. So to recap, you got leukemias in the bone marrow and blood. You got lymphomas in a lymph node. They can be acute if they get out of control, get very bad very fast. They can be chronic if they kind of don't cause that much trouble. They can be lymphoid if they're of the pre-lymphocyte lineage, or they can be myeloid if they're from the myeloid lineage. Now, how do leukemias and lymphomas present? Well, the good news is in USMLE complex questions, they basically tell you the patient's got a white cell cancer, and it is not very hard to figure it out. Typical symptoms are going to include fever, night sweats, chills, unexplained weight loss, and finally a lymphadenopathy. And it's going to be a non-tender lymphadenopathy. That's a very, very common presenting symptom across leukemias and lymphomas. So let's take a look at some practice questions for ALL so that you can get this presentation down pat and have no trouble recognizing it. Here's a 6-year-old girl with Down syndrome. ALL is the leukemia lymphoma you get with Down syndrome, which is a non-disjunction in meiosis 1, maternal non-disjunction of chromosome 21. This patient's presenting with fever and fatigue. She's also got a red rash over her arms and legs. Now that's a petechial rash, and that's due to a thrombocytopenia. And you also notice she's got hepatomegaly, as well as you do a CBC, and you see that there's also an anemia. So you've got 2 different cytopenias involved in this patient. White cells are normal, but then you look at the peripheral smear and you notice that there are blasts, white cell blasts in the peripheral smear. And so then the question is going to be, what's the diagnosis? And this is where you plug in your knowledge and you understand that ALL is essentially the childhood cancer. It's the most common cancer of childhood. It's also the most commonly lethal cancer of childhood. And so there's no way it could basically be any other cancer when it's presenting in a 6-year-old child. Another question that you can get out of the same stem is they can ask you what lab abnormality would you expect to see? And in this case, you would expect to see a neutropenia. And so why would you see a neutropenia? Wasn't the white cell count normal in this patient? Well, yes, it was. But remember, they have a white cell leukemia, which is a cancer that's growing in the bone marrow. And so when you have a cancer growing in the bone marrow, it crowds out all other lineages of cells inside the marrow, which explains why this patient has both an anemia and a thrombocytopenia, because there's something growing in the marrow. So cytopenias, you're almost always going to see one cytopenia. You're usually going to see two. Pancytopenia is rare because the white cell count in leukemias and lymphomas does tend to be elevated. It's a clonal proliferation of white cells. So cytopenia is very, very common presenting symptom along with the systemic B symptoms of fever, night sweats, chills, weight loss. Here's another similar presentation. A 6-year-old boy has had a fever for a week. He's been tired and weak. On physical exam, you notice hepatosplenomegaly and generalized lymphadenopathy, as well as a hemoglobin of 7.1 grams per deciliter and low platelets. So this kid's got an anemia and a thrombocytopenia. So you take a blood smear and you see atypical cells, which are also found in a bone marrow aspirate. And these cells stain positively for CD10, 19, and 20. So this is the most common variant of acute lymphoblastic leukemia, which is going to be your B cell variant. You know, it's a B cell cancer because it's positive for CD10. That's called CALA, or common leukocyte antigen. CD19 and CD20. Excuse me, CD10 is CALA. That's common ALL antigen. And so they just ask you, what's the diagnosis? And it's ALL. And in fact, because ALL is, again, essentially the childhood leukemia, if you've got a cancer question and the patient is below about 15 years of age, you can go ahead and put ALL for the answer. Now, sometimes they'll ask you what translocation would you see, or what is going to lead to a good prognosis or a worse prognosis in this patient. But if they just ask for the diagnosis, you can get that 10 times out of 10 by knowing the age brackets of these different leukemias. And ALL is the one that is particular to childhood. So how do we diagnose leukemias and lymphomas, specifically ALL? Let's walk through how you work this up. You're going to get a patient who's got fever, maybe chills, maybe night sweats, maybe unexplained weight loss. They're going to feel like crap, and they're going to have symptoms of an anemia, so pallor, conjunctival pallor, and they might also have symptoms of a thrombocytopenia, so petechial rash or recurrent epistaxis or gingival bleeding. And so based on those symptoms, you get your CBC. You notice that there's a cytopenia and maybe the white cell count's a little elevated there. You're going to get suspicious again, especially if this is a young child, and you're going to want to do a peripheral smear. And so after you do that peripheral smear and you see that there's a large degree of blasts or immature white cells inside the peripheral blood smear, you're immediately gonna want to take a bone marrow biopsy, and that's going to come usually from the posterior iliac crest. And then you're going to take the cells from that bone marrow aspirate and you're going to run some immunohistochemistry on them. You're going to look at them under a microscope, have a pathologist do it, and they're going to drop some stains on it. And the reason that they're dropping stains on this bone marrow smear is to tell you whether this neoplasm is of lymphoid or myeloid origin. And so they're going to do tests like myeloperoxidase, which is going to be exclusive to cells of the myeloid lineage, right? Over here on the left side of the screen. I mean, myeloperoxidase, it literally has myelo in it. And so these myeloid neoplasms will express myeloperoxidase, but lymphoid neoplasms will not. So that's one test we can use. Another is going to be this thing called TDT. This is an enzyme that lymphoid neoplasms express, but myeloid neoplasms do not. And so over 9 out of 10 acute lymphoblastic leukemias do express TDT on histochemistry and flow cytometry. So if you see that in a question stem, you're going to get clued in, oh, this is ALL. There is nothing else that it could be. And so from then, after you figure out this is lymphoid versus myelogenous, then the second step you're going to want to do is you're going to want to figure out, is this a B cell or a T cell lymphoblastic leukemia lymphoma? Because that's going to gauge prognosis and also determine how we can treat this cancer. So B-cell leukemias are more common, but if it's a lymphoma, it's going to tend to be a T-cell lymphoma, and this is only speaking to the acute lymphoblastic cancers here. And there are different markers that we can try to stain for to assess and see, is it a B cell or a T cell. What I want you to notice on the left-hand side of the page here is that these T cell markers are all in the single digits, and the B cell markers are all double digits, particularly between 10 and 22. If you see something in that range, it's probably a B cell marker. So 10, it's the most common, 19 another common one, and then 20, 21, 22, those are all B cell markers. You're dealing with a B cell cancer. Versus CD2, 3, 4, 5, 7, and 8, you're dealing with the T cell cancer. So then on top of that, you might want to get a karyotype, do some chromosomal analysis. You might want to sequence the DNA. And finally, you're going to pick the correct drugs, and you're going to get this patient on a chemotherapeutic regimen. And within a month, good news is at this point in time, we have some very good treatments for ALL. And most patients have a pretty good recovery rate, total remittance after treatment for this cancer. So that's the summary of ALL. Let's look at a case and then break down this SDL page by page. Here we've got a 6-year-old boy with upper respiratory symptoms, lymphadenopathy, bone pain, and easy bruising. And so bone pain is also a common symptom. Leukemia is a bone cancer after all. Physical exam reveals enlargement of submandibular, axillary, and cervical lymph nodes, hepatosplenomegaly and petechiae, that's a thrombocytopenia there, along with easy bruisability, that's low platelets that are doing that. So you look, and white cell count is extremely elevated with a differential of 86% blasts. That's a cancer right there. Specifically, that's a leukemia because you're seeing blasts in the peripheral blood. It's not just isolated to a lymph node. It's not a lymphoma, it's a leukemia. Bone marrow aspirate reveals a marrow that is greater than 90% hypercellular. So you start determining, is this a myeloid or a lymphoblastic leukemia? And the blasts are MPO negative. They do not stain positive for myeloperoxidase. So what that tells you is this is not AML, this is ALL that we are dealing with. Furthermore, you see that the blasts are positive for TDT, further confirming that this is ALL, and it's also positive for B cell precursor markers CD10, 20, 22, and 24, and negative for T precursor markers. So you're dealing with a B cell ALL here, which is the most common type of ALL, which is the most common childhood cancer. You start induction chemotherapy, and 2 weeks later, the patient's physical signs and lab values have returned to normal. The marrow is hypocellular with 1% blasts, and he's been discharged. So again, we can treat these ALLs. Now here at the introduction of this SDL is a good 5 or 6 pages of basic tenets of white cell cancers. So I'm going to go through this, and it's going to apply to all of the different white cell cancers that we will talk about on future SDLs. And if you want to skip to the good stuff and look at things particular to ALL, you can go ahead and go down and find that watermark point in the video and jump to it. Now, this SDL is saying that you've got many different ways to classify white cell neoplasms, but primarily we're going to call it lymphoid versus myeloid. And again, that's going to be based on what direction the hematopoietic stem cell wants to go in. And so lymphoid means it's going to become a T cell or a B cell. Myeloid means it's going to become a granulocyte. Now, you also have histiocytosis, which is discussed in, I believe, the splenic SDL. And the one disease you want to know about that is Langerhans cell histiocytosis. And a histiocyte is essentially a synonym for macrophage. And these are going to stain positive for CD1A. So that's going to set this cancer apart from any lymphoma, leukemia. It also likes to present as skin nodules and with kind of a eczematous skin rash. Lymphoid neoplasms is the next section we got. They're forms of blood cancer. The main difference is that leukemia affects the blood and the bone marrow, while lymphomas tend to affect the lymph nodes. So symptoms in leukemia are related to the cytopenias. If you've got low neutrophils, neutropenia, due to the fact that cancerous white cells are taking up the bone marrow, then you're going to be unable to fight off an infection. You're going to be more prone to getting a fever. If the cancer starts crowding out red cells, then you'll see all the symptoms traditional to an anemia. And the cancer is crowding out platelets. You get low platelets, you get bleeding and bruisability. So that's a leukemia. A lymphoma is a discrete tissue mass that's not in the bone marrow. It's a white cell cancer that is not in the bone marrow and not in the peripheral blood, but it is localized to a lymph node or lymph nodes, plural. Now, common areas for lymphomas include the tonsils, a lot of lymph nodes there. The appendix, that's essentially an immune organ or organelle, and Peyer's patches within the GI tract. There are lots of different types of lymphomas, and the best way to split those up are going to be Hodgkin's versus non-Hodgkin's. That's because every Hodgkin's lymphoma has these CD15 and 30 positive Reed-Sternberg binucleate allelized cells, and the spread of Hodgkin's lymphoma is much more predictable than the presentation and spread of non-Hodgkin's lymphomas. Both leukemias and lymphomas do like to present with the systemic B symptoms of fever, night sweats, weight loss, fatigue, maybe chills. And so those symptoms you ought to have a very high degree of clinical suspicion for. If you were to throw in maybe shortness of breath, dyspnea, and cough on top of that, then you've essentially got tuberculosis until you rule it out. And depending on the patient, fever, night sweats, and chills, you ought to be working up the cancer tree, looking at systemic inflammatory enzymes, maybe lactate dehydrogenase you want to try to get in order to rule that out. Because again, this is the classic textbook presentation of a blood cancer. Now, when we're diagnosing white cell cancers, you have to take a biopsy. And so that's usually given to you in a test question stem. So know the different markers, the clusters of differentiation. They're going to essentially help you navigate or read the map when it comes to the test question. And that's exactly what the STL says next. Here's a bit of a table on this one page. This table is going to apply to all the white cancer STLs. And you can refer to it as necessary if you're a table type of person, but I'm skipping it. So back to the main point, they want you to know clusters of differentiation. I've listed a lot right here. So if any of these are brand new to you, go ahead and take a minute to jot it down, make a note of it somewhere so that you recognize it down the road. Now, CD1, that's going to be positive in histiocytes. So that Langerhans cell histiocytosis, always positive in that cancer. CD3, 4, and 8, those are typical T cell markers. Remember, you have helper T cells, and those are CD4 positive, and cytotoxic, and those are CD8 positive. Then Hodgkin's lymphoma is going to be CD15 and 30 positive. Some common B cell markers are going to be 19, 20, and 21. Neutrophils like to stain for CD18. And finally, all white blood cells will stain positive for CD45. So if you ever get CD45, you're looking at a white blood cell. So again, you're working the patient up. You take a biopsy because you have to. You figure out, is this lymphoid or myeloid? First step. Second step is going to be, if it's lymphoid, is this a B or a T cell lymphoblastic neoplasm? So when it comes to acute leukemia, most of them are going to be B cells. A lot of big picture points here. Another section telling you that B lymphocytes like to express CD10, CD19. That TDT enzyme is going to be present again in almost 100% of acute lymphoblastic leukemia. TDT right there. That's a big one. T lymphocytes again express CD molecules or CD markers that are numbered under 10, 2, 3, 5, 7, 4, and 8. So those single digits are going to be your T cells. Natural killer cells, a couple of CDs associated with those are going to be 16 and 56. And so those have 6s in them. You can just remember them as the ones that have 6s in them. So now we get to the money part of this SDL, the more specific discussion of this SDL, ALL itself. So leukemia is a white cell cancer that is in the bone marrow and or the peripheral blood, and a lymphoma is a white cell cancer that is not in the bone marrow and is not in the peripheral blood. Now, you can have an acute lymphoblastic leukemia or lymphoma, okay? And out of that acute lymphoblastic leukemia or lymphoma, both of those can be either B cell or T cell in origin. So there's really 4 different types of ALL that we're dealing with. There's a B cell leukemia, a T cell leukemia, a B cell lymphoma, and a T cell lymphoma. So this ALL disease process kind of has 4 big subcategories to it, okay? So how do you tell them apart? Well, you do a peripheral blood smear and you count the total number of cells in the smear, and then you calculate the percent of cells in the smear that are abnormal lymphoblasts. And if that percentage is greater than 25%, so if more than 1/4 of cells in the peripheral smear are blasts, you're looking at a leukemia. If less than 25% are blasts, let's say that you've got blasts in the peripheral smear, but it's at 12%. What that means is that you do not have ALL. The patient has something else that is not ALL. And a lymphoma, again, characteristically presents with a bulky, non-tender lymphadenopathy. And they're going to give that to you in the question stem. And there are no blasts in the peripheral blood or the bone marrow. So 25%, that is big, big, big. Understand that if it's over 25%, you're dealing with a leukemia. If it is under, you do not have leukemia. So how this SDL is structured, first we talk about B cell leukemia and B cell lymphoma. Then we talk about T cell leukemia and T cell lymphoma. And I like that a lot because no matter if it's a leukemia or a lymphoma, the CD markers expressed by a B cell cancer will be nearly identical in both leukemias and lymphomas. So again, one more time, that big principle. If you see it in the peripheral smear, if you see it on bone marrow, greater than 25% blasts, it's a leukemia. If the blasts are not in the blood smear and not in the bone marrow, but you do have a big old lymph node, it is a lymphoma. So B cell ALL. First off, know the CDs. You got 10, you got 19, 20, 21, and 22. That's it, really. B cell ALL is the most common ALL. It actually has a bimodal age distribution, so adults can get this too. You can have a chronic lymphocytic leukemia that kind of mutates into an acute lymphoblastic leukemia. So it's rare, very rare in the elderly population, but they can get an ALL. And then lymphoblastic lymphoma, or LBL, that's essentially ALL, but in a lymphoma form. And out of all LBLs, out of all acute LBLs, because remember, acute means, oh, the disease got really bad really quickly. And then chronic means, oh, I've had this lymph node for 3 years and I'm fine. So out of all acute LBLs, T cell LBLs are going to be 9 out of 10 cases. So when it comes to an acute leukemia, acute lymphoblastic leukemia, B cells way more common. When it comes to acute lymphoblastic lymphoma, T cells way more common. Now, how do you get a leukemia? What's the driver mutation? Well, we believe in kind of a two-hit model right now, wherein the first hit is going to be a translocation of some sorts or a hyperploidy, essentially an overduplication of a few chromosomes. So that's going to be one hit, right? That predisposes a cell to becoming cancerous. But then we believe that the carcinogenesis of white cell cancers is accelerated by infections, which mediate an appropriate white cell response. So think about it. You get a viral infection. How do you fight off viruses? T lymphocytes. Well, how do you get more T lymphocytes? You upregulate lymphoid differentiation. And so those lymphoid progenitors will be dividing. So if you have a lymphoid progenitor that has already gotten a first hit in the form of a ploidy or a translocation, then that rapid cell division in response to an infection, that step 2, is going to send it into overdrive and possibly kick it into cancer. That's etiology there. Thinking about clinical presentation: fever, night sweats, chills, bruisability, petechial rash, symptoms of anemia. They're going to tell you the patient has ALL, essentially. This is a good table here, table 3. It's reminding you first that it's not leukemia unless you've got 25% or more blasts in the smear or in the bone marrow. And also reminding you that one of the very first things that you should do when you see blasts is try to figure out, are these myeloid or lymphoblasts? And so a good test for that is going to be, again, myeloperoxidase. If the blasts are of myeloid differentiation, they'll stain positive for MPO. If they are of lymphoid generation, they'll stain negative for MPO. I would like to point out that leukemias can still, because they get in the bloodstream, they can go to any organ in the body, okay? So you can have a leukemia in your bone marrow and bloodstream that can present as a brain mass or as hepatosplenomegaly. They can get in the kidneys, they can get in the gut, they get in the skin. You can get a skin leukemia. And again, that's going to be because these blasts are in the bloodstream, they can go anywhere in the body. So don't think that just because it's a leukemia, it's only in the bone marrow. Got it. Quick clinical pearl, not the highest yield on tests, but for real life, whenever you get a testicular mass, had a clinical medicine lecturer actually tell us, if you see a testicular cancer in a young dude, it's a primary testicular cancer. If you see a testicular cancer in someone who is 60 or 70 years old, there is a big chance that that is a white cell cancer rather than a primary testicular cancer. So keep these white cell cancers on your differential for testicular involvement in old men. Now, some general markers of, hey, this patient has a cancer, are going to be lactate dehydrogenase and beta-2 microglobulin. So the reason that these molecules go up in the blood whenever you have a cancer is because cancer cells die. You know, all cells die eventually, but cancer cells are really labile cells. And so they're dividing. And if there's a mass particularly, then tumor cells like to get a central necrosis inside that mass. And when they do get a central necrosis, a lot of cells are going to die and release their contents into the surrounding bloodstream. And so lactate dehydrogenase gets put in the blood when cells die, as well as beta-2 microglobulin, which is pretty specific for white cell cancers because beta-2 microglobulin is actually a little protein part of the MHC1 molecule. So lactate dehydrogenase, really non-specific. All cells have that, but beta-2 microglobulin is part of MHC1, and really only immune cells are going to express that. So both of these are reflective. If they're high in the blood, they reflect high degrees of cell death, as you would see in cancer. And we start thinking about, how does B-cell ALL look on a smear? That's essentially all you got to know, because if they show you a bone marrow, like look at this one on the right, there's no fat in there at all. It's so hypercellular. It is just packed with lymphocytes. You can tell that they're lymphocytes even at a low magnitude, because it's just dot, 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 dot. And if you look at cells in a peripheral smear, you can identify blasts by their very high nuclear to cytoplasmic ratio. So that's going to go for both myelogenous and lymphocytic leukemias, okay? Very, very big nucleus compared to their cytoplasm, barely any cytoplasm at all. And that nucleus is going to be a very dark or dense purple. Here's again ALL. Big nucleus compared to cytoplasm. And also, because these are blasts or immature white cells, they are significantly larger than red cells in the area. And so look at how big these white cells are. They're about twice as big as those red cells. They shouldn't be that much larger. That's how you know you're dealing with blasts. Here's another good image. ALL versus AML. You see blasts in both of them. A slight difference is that in AML, you've just got a little bit smaller nucleus and a little bit more cytoplasm. So that nucleus to cytoplasm ratio shifts a little bit to the cytoplasm, versus acute lymphoblastic leukemia here on the right. I mean, some of these cells, you literally can't see cytoplasm. So a slight difference, but a difference nonetheless in the visualization of AML versus ALL. And that's about all I got to know about the pathology, because again, they're going to tell you in the question stem, hey, this child has had fever, night sweats, chills, and cytopenias. And you're going to be like, I wonder what this is. So here's a flow cytometry diagram. And whenever we do flow cytometry, we're essentially looking for the presence of different DNA transcripts within cells and different cell surface markers. In this case, we're looking for CD10 and CD19, which are two B-cell markers. And because the majority of cells in this particular population express both CD10 and CD19, we know we're dealing with a B-cell ALL. And if we did this exact same tests and all the cells came back in this left lower quadrant of the graph, we would be thinking this is probably a T-cell leukemia rather than a B-cell leukemia. One more time, with B-cell leukemia, there can be significant organ involvement. Just because it's a leukemia doesn't mean it's only in the bone. The brain is very often involved in ALL. If you see a primary cancer in a kid in the brain, leukemia should be on your differential. Not primary cancer, take that word out. Here's an example of skin involvement on the mandible right there. And you know it's skin and not an underlying lymph node, because you take a biopsy and you see lymphocytes in the dermis. So again, not just bone marrow involved here. Lymphomas like to involve the skin and the bone. So I will take the time out to make a really, really minor detailed point. The SDL says nothing about B-cell leukemias being in the skin, but it does specifically mention B-cell lymphomas like to go to the skin. A little difference there. So again, you've patient's got a leukemia, blasts on peripheral smear, or blasts in a lymph node. They have a lymphoma. What's your next step? Figure out, is it myeloid or lymphoid? And so a good way to do that is going to be myeloperoxidase. Also, this enzyme NSE, that stands for non-specific esterase, which is particular to monocytes and macrophages. And so if either of these were positive, you would be dealing with a myeloid cancer. But if they're negative, you're dealing with a lymphoid cancer. Flow cytometry, this is the third or fourth time that this topic has popped up in this SDL. It's very, very important. You know the clusters of differentiation. B cells, double digits, 10, 19, 20, 21, 22, 24, on down the line. T cells, single digits, 2, 3, 4, 5, 7, and 8. And big point here is that this TDT, terminal deoxynucleotide transferase, is an excellent marker of lymphoid blasts. So if it's negative for NPO, but it's positive for TDT, you've got ALL. It cannot be AML because TDT is really only expressed on lymphoid blasts. Now we get into genetics particular to B-cell leukemias and lymphomas. And then we're going to talk about this and then do the same thing for T-cell leukemias and lymphomas. So pay attention to both, take notes. There's not too much they can ask you about this stuff. It's not a lot to remember. First off is ploidies, hyperploidies or hypoploidies, meaning you have too many or too little chromosomes. So you could diagnose this with a karyotype or with a fish, fluorescent in situ hybridization. And I want you to know that only the B-cell leukemias and lymphomas will have ploidies. So T-cell leukemias and lymphomas tend to have a standard 46 chromosomes. Got it. Now, there are two translocations you need to know that B-cell leukemias and lymphomas might present with. One of them has a good prognosis, the other has a poor prognosis. The one with a good prognosis is this 1221 translocation. If you see a B-cell ALL or LBL and it's got a 1221 translocation, that's a better prognosis than most other B-cell cancers. However, if you see a B-cell leukemia lymphoma and it's got a 922 translocation involving the Philadelphia chromosome, that is bad news, because those cancers are very aggressive and very difficult to treat. Now, the Philadelphia chromosome is a fusion protein between this ABL gene, ABLA, and the BCR gene, that stands for breakpoint cluster region. And it essentially takes these two proteins that would otherwise be separate, and it just glues them together so that whenever you make an ABL, you also make a BCR. Whenever you make a BCR, you also make an ABL, because the promoters are going to be close to one another too. So you can't make one protein without the other. In fact, they're stuck together. And this fusion protein has a different function than ABL and BCR. It's got a totally different function than either of those two individual genes. And so this fusion protein is going to make cells grow and divide. That's why it's associated with cancer. And one last point I want to make is that this Philadelphia chromosome is actually different than the Philadelphia chromosome that you see in chronic myelogenous leukemia, or CML. That CML is basically defined by the Philadelphia chromosome, and it's the same 922 translocation, but it's just involving slightly different regions of DNA. So the fusion protein itself is different. So we have drugs that are really good at targeting the CML BCR-ABL product, but not all those drugs work as well on the ALL BCR-ABL product. Add into the fact that this is an acute leukemia and you've got a little bit less time on your hands to work with if you're the clinician, and you can see why this translocation is going to lead to a poor prognosis. So recap of the B-cell genetics. Only B-cell leukemias and lymphomas have ploidy problems. 1221 is a good prognosis translocation. 922 Philadelphia chromosome is a poor prognosis. Now let's talk about T-cell lymphomas and leukemias, acute lymphomas and leukemias. These are going to be a minority of leukemias, but a majority of acute lymphoblastic lymphomas. Again, T-cell antigens are 2, 3, 4, 5, 7, and 8. And if you look in the peripheral blood and you count the cells, and more than 1/4 of them are blasts, you're dealing with a leukemia. If not, you don't have ALL. If you take a lymph node biopsy and you see a bunch of blasts in there, then you consult the peripheral smear. If it's under 25%, you've just got a plain lymphoma. So underrated, kind of subtle or muted yet significant fact here. Both T-cell leukemia and lymphoma show a male predominance, and patients are usually in their teens to early 20s. So that's a little older than a couple of the 6-year-old kids that we looked at in these cases earlier in the SDL, right? So patients are usually in their teens to early 20s, and they're guys. Say that one more time. Now, clinically, how do they present? Well, T-cell leukemia looks just like B-cell leukemia, except it's got T-cell markers instead of B-cell markers, okay? We're done with T-cell leukemia. T-cell lymphoma, get this. Acute T-cell lymphoblastic lymphoma prefers the thymus, because the thymus is where T cells grow up and get educated. There are a ton of precursor T cells there. So if you have a precursor T cell cancer, doesn't it make sense that it's going to be in a big swollen thymus? Yes, it does. So these like to present, T cell lymphoblastic lymphomas like to present as a big swollen mediastinal mass in a guy in his teens to early 20s. And that's going to be the test question. So you can get superior vena cava syndrome here. You might get Horner syndrome. I don't know. Weird stuff happens with tumors as a result of the compression from that mass. Recurrent laryngeal nerve is way back in the back. Remember, you can always get hoarseness, trouble speaking because of compression of that structure. Sentence here, histologically, T-cell lymphoblastic lymphoma is an infiltrative process that diffusely replaces the lymph node follicular architecture. So this is my call out. B cells live in lymph node follicles. They live in germinal centers, which are the same thing as follicles. T cells live in the pericortex of lymph nodes. They live around the follicles. So never forget that. You probably will. T-cell markers for like the 5th time this SDL, 2, 3, 4, 5, 7, and 8, you know? And of course, if it is a leukemia lymphoma of lymphoid origin, it's going to express that terminal deoxynucleotide transferase. That's a big point. Here is the last good little chunk in this SDL, major genetic anomalies of T-cell lymphoma and leukemia. You got 2 different translocations and they both have a 1 in them. You got 114 and 17. So if you see either of those, you're looking at a T-cell cancer. And then you've got cyclin-dependent kinase loss of function mutations. And then you've got Notch gene gain of function mutations. And so what I would really highlight from here is that the Notch gene is a gain of function, okay, y'all? Because they can always give you the question and have it be like Notch 1 gain of function, Notch 1 loss of function. So you want to know it's a gain of function specifically. And these cyclin-dependent kinase inhibitors, they are loss of function mutations. Now, this SDL does have a really great kind of summary paragraph on P14, 15, and 16 and how they interact with cyclin D and CDK4. Remember that cyclin D and CDK4 complex with one another to hyperphosphorylate this retinoblastoma protein. And whenever RB gets hyperphosphorylated, it's got a ton of phosphates on it, then E2F is freed from RB's clutches. E2F goes to the DNA and activates transcription. That's how you go from G1 to S. So this is something that is pretty good to have in your pocket for board examinations. Now, the fact that cyclin-dependent kinase is going to phosphorylate RB, okay, you should never forget that. What does a kinase do? It phosphorylates. So that's why RB's got all these phosphates on it. And then the final piece of the puzzle is going to be that P16 and P14 inhibit cyclin D and cyclin-dependent kinase. That's why P15 and P16 are called INK4A and INK4B. INK, INK stands for inhibitor of kinase 4. Okay, makes a lot of sense. So there's this gene. It's called T-cell ALL protein 1 or TAL1. And you want to know that this gene is going to be overexpressed in the majority of T cell leukemias, and that both of the translocations in this table affect this TAL gene. So the translocation leads to a mutated gene product. It's a gain of function. And then you got Notch, and that's cell-cell interactions. And again, you're going to have a gain of function. The Notch protein, normally how Notch functions is it's bound to a neighboring cell, and that's going to send a signal to transcribe genes. Now, if you just upregulate Notch, because we said it's a gain of function, what that means is that a cell with increased surface Notch is going to be more capable of getting growth factor signals from its neighboring cells. And so it's going to be easier for that cell to kind of gain XP, if you want to think about it as like an RPG character or something. So that's your T cell leukemias and lymphomas. The two tables with the genetic anomalies are really good to know. Other than that, you just rep the high yield markers for these B cells and T cells, as well as understand TDT means that you have a lymphoid cancer, and you are going to be pretty chill for this SDL, because one last time, the diagnosis is super easy. You've got a kid. ALL is a kid's cancer. You got a kid with fever, chills, weight loss, bruising, thrombocytopenias, maybe an anemia, and a big elevated white count. And if their peripheral smear is greater than 25% blasts, it's leukemia. If not, and they just have a lymphadenopathy, it's a lymphoma. All right, you got ALL down pat. See you next time.